away then, and I'd like to introduce Associate Professor Judith Trotman, who's from Concord Repatriation General Hospital and also from the University of Sydney. And she's going to be presenting on a multidisciplinary team model using a standard operating procedure and patient proforma to ensure quality peer review. Thanks, Judith.
Thank you for that very warm welcome, and hello everybody. It's a real pleasure to present to you the results of 3 years patient endeavour by my colleagues at Concord Haematology at the Concord Cancer Centre, who have developed an MDT model centred around both a standard operating procedure, around a patient proforma that ensures quality peer review for our patients with blood cancers. And this is the work of a number of key people, but importantly also Jimmy Trin, one of our research unit data managers who developed the proforma. Every time I kept asking him to adjust it, he did, and he kept coming up with the goods. And also someone who's not actually listed as an author and really should be, Elizabeth Sedlicker, who's our MDT secretary, who's been responsible for so much of the SOP. MDTs are very much the buzzword in cancer care, and for very good reasons. You'll see the core team members in our MDT listed down there, but what I'd actually like to do is take you back to 2008 when we thought, look, we better have a bit of consensus agreement and peer review of our difficult patients. And so what we did every fortnight was we started this sort of round table discussion, and the haematologist would have the patient file, they'd flip through the patient file in their lap and present the scenario. There was no formal anatomical pathology or radiology involvement, and certainly no formal documentation other than an illegible scrawl by myself or another haematologist into the patient's file. And we decided in 2010 that just wasn't good enough, and we wanted to develop an efficient process for quality, documented, multidisciplinary peer review of patients with haematological malignancies. And this is the key slide, all right? This summarises all our methods and results in one effectively. And you can see up there on the right-hand corner an example of the proforma, which I'll actually go through in great detail with you in a moment. But basically it starts on Monday morning when the MDT secretary emails a meeting alert to all the team members, and on that alert is this intranet hyperlink to the latest iteration of the proforma. Now, the treating physician or the advanced trainee will complete the patient proforma outlining the diagnostic workup and the proposed management plan, and submit that electronically online back to the MDT secretary by 3 o'clock on Wednesday afternoon. And then she hurriedly prepares the meeting agenda and alerts the anatomical pathology and radiology departments of the patients who are going to be presented the next morning. Now, after our inpatient ward round on Thursday afternoon, we all try and scurry down and be there at 10:45 in the morning in the anatomical pathology meeting room to do our AP cases alone. And then that merges into our MDT meeting, and then merges into our radiology review alone meeting, so we can all be out and down at ground rounds at 12:30. So you can all appreciate that that is a very ambitious schedule. But it generally does work with patients, doesn't it, Shiraz? Provided the chair was pretty ruthless at timekeeping. Now, during the meeting, the chair will display the proforma on an audiovisual screen and scroll through it while the treating physician presents the patient's summary. Now, the radiology and pathology are reviewed alternately, displayed alternately on a second screen. The diagnostic workup and proposed management is discussed. Management consensus is usually reached and recorded on the proforma. If there's not consensus, that's recorded, and the proforma is verified by the chair in real time, converted to a read-only PDF that gets posted to the referrer, put into the file, and loaded onto our electronic medical record. Here's an example of the meeting agenda, where you'll see there the patient's different diagnoses and the different boxes that have been ticked as to whether they need CT, pathology or radiation oncology review. And it's nice to see that agenda and get a sense of whether it's going to be a very interesting MDT meeting or not. And here's an example of what actually happens. So the MDT chair sits there at the laptop and edits the proforma which is displayed up on the screen here. I've just patched one in for you. While the radiologist here on the left and the pathologist out of view here will show in the radiology and histology on another screen. Now, if you want quality peer review of your patient care, you've got to give quality data, and you've got to give a succinct but comprehensive patient synopsis to your colleagues. And so we searched for a while, and we found that the really best way of doing this was putting the data on a Microsoft InfoPath, that's InfoPath, not InfoPath, flat form. And that, unfortunately, is not actually a database, but it's the best functionality. It's a software application for the design, distribution, and submission of structured data within an electronic form. And the beauty of it is this what you see is what you get interface. So if you're changing something, adding in a little extra treatment modality or prognostic index in the back, you see it straight away in the front of the form. Instead of, say, with the old Cerner system, you would email the IT department and maybe 4 months later you might get a change to the form. So, starting from version 1 in October 2010, we've essentially kept the same logical order of the patient and patient parameters, with identifiers, their medical and social history, the current presentation, the diagnostic workup, and then, absolutely key, no one gets past the door without having a proposed management plan from the treating physician. And then what is on the Proforma at the bottom is an empty free text box for the recommended management plan that has been derived at as a consequence of the peer review. Now, in the Proforma, patient diagnoses are separated into 5 categories: non-Hodgkin's, Hodgkin's, lymphoma, myeloma, chronic lymphocytic leukemia, and then the other leukemias and myeloproliferative diseases. And then within each category, there is further breakdown into every single specific histology that's listed in the WHO classification. And if you select a specific histology, that will reveal only the tick boxes and drop-down menus that are relevant for the staging, prognostic indices, and treatment protocols for that given histology. And constant refinement and feedback over the years has very much been focused on making it as easy as possible for busy clinicians who don't want to fill out another form to complete the form, and to capture the comprehensive relevant data for that individual patient in an optimised layout for very quick absorbing of the information. So let's go through the MDT Proforma bit by bit. Here is a patient of mine who I wish radiology and pathology review, and this 55-year-old previously well Hungarian-Australian security worker has an ECOG performance status of 0. He presented with a few weeks of abdominal pain. I felt a mass, and the CT, PET scan and core biopsies confirmed he had a low-grade follicular lymphoma. So as soon as I click in the NHL circle here, I get this long drop-down menu, and from which I have selected follicular lymphoma. If I can't remember my Ann Arbor staging criteria, what I have to anyway, I have to click on this box and click the relevant staging criteria, which identifies that he is stage 4A disease, and he's clearly someone with newly diagnosed lymphoma. Because he has follicular lymphoma, the flippy prognostic index comes up here, and I didn't have to tick any of these boxes, showing that he did not meet any of the poor prognostic criteria for his disease. This is an example of the back end, all right? This is the data dictionary. When you click on that NHL box, that seemingly innocuous, simple box at the front breaks out to more than 20 different histologies, all linked to their relevant prognostic indices. Being haematologists, of course, we want to record the patient's blood counts, the relevant biochemistry. Because he's got follicular lymphoma, beta-2 microglobulin comes up as a relevant prognostic factor. And a very important reminder to us as clinicians, the free text box for viral serology reminds us, oh, I haven't done the viral serology, better go and do that, which has been fantastic. And then at the very bottom, we have what I have entered my summary of the patient and my proposed management plan, which fortunately my colleagues agreed with, and this patient was enrolled in the gallium study. This Proforma was verified by the chair of the day, Dr. Curnow, with the relevant attendees ticked in the relevant boxes. And this is a whole screenshot of this patient's Proforma as verified and posted to the GP. It's a lot of work for our secretary in driving the meeting standard operating procedure, but also in documentation of the MDT process and the billing process, and that would take another whole half hour to go through for you, so I'm not going to. Other than to say that we're very conscious that probably we're the first haematology department in Australia to bill for our MDTs. So we have been meticulous in making sure we meet criteria should we ever get audited. And we've become very aware of the fact that the Medicare benefit schedule is very much geared up to an MDT of someone with, say, breast cancer who has surgery, radiotherapy and chemotherapy. Nonetheless, we set our own parameters for what we think meets the criteria, and we also make sure we notify the patient in writing as is required for MDT billing purposes. So we went and did an audit after 30 months of operation, and we wanted to review the verified Proformas to identify the level of concordance between the treating physician's proposed management plan and the consensus agreement of the MDT. Now, I can't go through this in great detail, but we were quite pleased by the audit results. Of the first 413 patients, we had almost 80% agreement with the proposed management plan. And what we defined as being a significant recommendation to the management plan occurred in 9% of patients, and it generally involved giving an additional chemotherapy agent or a change in the actual chemotherapy protocol suggested. And pleasingly, we actually captured an additional 12 patients for clinical trial participation. A minor recommendation to the management plan was generally the additional investigation, such as viral serology or beta-2 microglobulin. And absolutely delighted that only because of that rigorous requirement for MDT submission, only 2% of the results in terms of the verified Proforma were actually ambiguous for our purposes. So to conclude, we really felt that we had achieved our primary aim of quality peer review. But akin to Professor Sebeson's presentation about telehealth and discovering the other benefits of a telehealth program, we noted in particular patients loved the fact that their case was going to be presented for peer review. There was a lot less repetition of patient discussion. We all stick with the ambitious time schedule because we know the other option is going to 3 different meetings. We have improved record keeping and cancer registry data. We have streamlined clinical trial screening, Medicare billing, which probably is not worth the effort financially, but it's certainly also very educational for all. Especially our advanced trainees getting exposure to outpatient haematology practice, and it certainly prompts haematologist self-review and a lot of pre-reading before you submit your patient for review, and naturally it's a platform for ongoing audit. A couple of ongoing challenges. One that I mentioned earlier to you today was, of course, the involvement of allied health, which we do have, but only in a limited way. Balance between the timeliness of peer review and the completeness of that review when there is obviously an urgency for many haematological malignancies to start treatment. Ongoing revisions to the Proforma are actually not challenging, but certainly required to meet the ever-changing nature of cancer care. We never got any additional clerical support, so our poor secretarial staff feel a bit burdened by this. I'd love to have a database version which maintained functionality, but I just don't think that's possible. And we're very keen on getting a PET webinar, but a little bit trepidatious about that also, because that will certainly also slow down the conduct of the meeting. Nonetheless, quality multidisciplinary peer review has become integral to patient care at Concord Haematology, thanks to considerable collegiality amongst my colleagues who have a shared commitment to efficiency, thanks to ongoing refinement of the SOP over 3 years by all my colleagues listed below. Thank you very much.
So So, please note down your questions so that you remember them for when Judith comes back, and she will be. I'd like to now introduce you to our second speaker, who's Dr. Christine Sanderson, who's a staff specialist at the Concord Repatriation... at Calvary Hospital. Sorry, I don't have my reading glasses on, so this is actually quite tricky. So she's at Calvary Hospital, Sydney, but she's also a medical advisor with Care Search. And her topic today is early routine family meetings can improve the transition to palliative care. Please welcome Christine.
Thank you very much. That was a great talk. It was one of those things where you hear it, it's so obviously like, why haven't we been doing this? And I think this project is a very similar kind of thing, a simple idea, but one that we've learned an awful lot from, and doing it in a research context has been very enriching. So I want to talk about these family meetings. Family meetings is something that I remember as a junior doctor, many of my colleagues used to dread and run away from, but we do a lot of family meetings in palliative care and regard them very much as a therapeutic process, really. But the questions I've had as a clinician doing these meetings is really whose issues are we dealing with in these meetings? There is some research around suggesting that the patients' and families' voices are often not heard. I have often wondered whether the meetings are beneficial or traumatic on balance, and what the timing should be for these family meetings. We do have some guidelines. These guidelines came out from a Victorian group in 2008, but not on a background of a huge amount of research, I would have to say. And they were very much a kind of a consensus expert opinion set of guidelines that set a very high bar, and we read them and thought, oh my goodness, what do other people do? Is this anything, like reality? And that started us thinking much more about the family meeting concept. We started to think about what it is we're actually doing in our family meetings, and looking at it, I would have to say that generally speaking it's a very reactive process. We hold family meetings in general when the team is concerned about a family or when we're at some kind of a turning point that we want to inform them of. So it's certainly not routine, which is what is recommended. It often occurs quite late in the admission, so all sorts of stuff has happened and all sorts of water's gone under the bridge by the time we sit down with a family and talk to them in this very formal way. And mainly the reasons for the meetings are discharge planning issues, by which I mean the good thing, what's usually a good thing, of going home, but also the less good thing, sometimes the fate worse than death, which is a nursing home placement, and those are very traumatic meetings. And the dynamic, which I could, for those of you who don't work in palliative care, if you can imagine you've got a 4-bed bay and the person in that corner has been talking to the social worker about the nursing home placement, and the families in the other 3 corners have been listening very closely, and when the family meeting suggested to them, the level of angst starts to get very high, and actually some of those families stop coming to the hospital and are very hard to get hold of at that point. So these family meetings are not fun for anybody. And then of course the other thing is to discuss goals of care and prognosis. And goals of care, again, is sometimes code for families who are really not getting it, who are really, need to be, have it explained what's really going on. Again, these can be quite distressing meetings sometimes. These are all very reactive family meetings. I mean, family meetings are also, positive and helpful in our routine practice, but there's a level of angst around them that has always impressed me and our junior doctors, I think. So the research question, based on the guidelines and based on thinking about our practice, was, would it be helpful to have a different kind of family meeting, a routine early family meeting for newly admitted patients? And we were thinking about it as a different kind of process from the family meetings that we were doing and we were driving. And we hypothesised it would be possible to hold meetings that would improve communication, decision-making and discharge planning, improve family participation, reduce levels of distress and for both patient and family during this major transition from acute care to palliative care. and would be much more patient-centred and involve patients than our usual family meetings. And I guess having heard those, all those ideas, the Cancer Institute gave us some money to do this. So we've had a year of funding which allowed us to have a social worker working 1 day a week alongside her usual work, and so she came on board as a researcher, a first-time researcher, and actually has absolutely loved it and is quite keen to do more. And what she did was we spent a lot of time designing a methodology and data collection tools and so on, which I'm not going to give you much detail about, but it was certainly a careful process. But what she did once we'd done all of that was start recruiting, obviously, and consenting consecutive patients for upfront family meetings, as we call them. So these are all patients coming to palliative care for the first time. We do have patients who have multiple admissions, so they were not eligible. We figured they'd been through the trauma, they're coming back for the second or third time, they know us. The ones we wanted to pick up in this process were the ones who were coming for the first time. They're like, oh my God, I'm at Calvary. What we gave them was a written invitation which said, you know, please, would you like to meet the team? Would you like to invite your family? It's a chance for you to talk about anything you want to talk about. So we really were handing over the whole process to the family and saying, it's your agenda. Some patients took big advantage of that. I had a couple of patients who literally chaired the meeting and closed it when they'd had enough, which was fantastic, absolutely fantastic. I loved that. At the time they were recruited, the patients were interviewed by the social worker. So just a brief interview, checking on their expectations, finding out from them who they thought was affected by their illness. Because the other thing I noticed about family meetings is we choose who to invite in our usual family meetings. On this occasion, the patient got to say who they felt was affected, and they could invite them if they wanted to and thought it was appropriate. What are their concerns? And then a research question. So this is a validated assessment tool, really, which is the question, are you at peace? Which was interesting. The meetings were held, attended by the psychosocial team, by which I mean social worker, pastoral care and medical, which was me. And then they were documented very carefully, and we've got a lot of detailed documentation from these meetings that we're still working through. The patient, obviously, and any family they wish to invite. Afterwards, we got written feedback from family members, and we undertook a follow-up interview with the patients whenever we could. We tried to compare with our usual practice. Now, we're not a huge service, so there's not that many staff there. What we did was allocate patients who were under me were on the intervention side, and patients under the other two consultants were on the standard care arm. And we consented them, we did a baseline interview, and then we just watched and waited to see how many of them would actually get an interview, when that interview would happen, and the research social worker observed those meetings and evaluated them. So that was an interesting process. We did get a little bit of data about our usual practice. So during this period we managed to consent 55 patients, which we thought was fairly good, and I think this may well be the largest study of family meetings from my reading of the literature. I need to go back and have another look. But it's not a well-studied phenomenon. So in the standard care arm there were 24, in upfront meeting arm there were 31. I'm still not quite sure why there are, you can see the female genders, 23% in the standard arm, 38% in the upfront arm. Not quite sure why that's not a 50-50 kind of thing. I need to have a think about that. But basically, and again, the non-English speaking background is very different in the standard care arm from in my own arm. And that may reflect perhaps a little bit the different patient mix that I have from the other consultants. I do have more of the non-English speaking background patients. But it was good to have them in the study. Made it very interesting. So actually looking to see what happened, the number of meetings that were held in the standard care arm, just over a third of those patients that we recruited actually went to have a family meeting. And of those, 2/3 of the patients actually were present at the meeting. And the average day on which that meeting was held was round about what I thought was day 13. And some of them, obviously that's a mean, as some of them were sort of closer to a month after admission. We do have some long stays, and often long stay is the other trigger for family meetings. On the Upfront Family Meeting side, we managed to get 83% of them through to a meeting, and I'll tell you the reasons in a minute why meetings weren't held. And of those, all but one of the patients came to the meeting, and the average day in which the family meeting was held was day 5. So that was getting close. We were hoping to do it in the first week of admission, and we were pretty close, and we were pleased about that. We'd like to do it even more quickly if we could. So this is the reason the patients who didn't make it to their upfront meeting. One patient died, a couple were just too unwell. One we realised was not eligible, and this was in fact because we realised there was a domestic violence situation, so it seemed very inappropriate to have this kind of a family meeting for a patient in that situation. And then in the final one, the family member just bailed. So what I'm going to present now is the first part of the data that we've tried to look at closely, which is actually what is discussed in family meetings, and it's an interesting thing. These are the, as we coded the data, we've got a lot of qualitative data. These are the kinds of headings that we've been able to code them into. So a lot of what we're doing is talking about symptoms and problems, as you'd imagine. Advanced care planning is our bread and butter, and by that I mean talking about prognosis, talking about, we discuss symptoms, then it's like, well, what does that mean? You know, I'm very tired, I can't breathe well. What does that mean? So we talk about that, and I class that under advanced care planning. Goals of treatment, so what can we expect from the different treatments we offer? And preparation for death as well. So that actually, interestingly enough, I haven't found it talked about so much in family meetings in the past, but when I looked at this, the results, you'll see that it comes up a fair bit. Relationships and coping, understanding this particular family, so getting a real handle on how this family works and what's going on with them, and then for them to understand palliative care. So you hear in palliative care, what the heck does that mean, and what can you expect from us? So our numbers are small, so I don't want to get too excited about some of the differences here, but I think we, certainly in both arms, these issues were pretty much core issues that were being talked about. So the different symptoms that people were talking about. Families identified a problem often. Patients' mood and cognition, very important issues for families. And families were often raising this, which is great. This is what comes in under the advanced care planning, and you can see that it's going on in both the standard and the upfront meetings. We invited patients to ask what to expect, and that was part of our Proforma. This is where they start to look a bit different. One of the things that came up when we allowed the patients to lead the meeting was their concerns about all of the family around them. And this, you can see, is a very, I think, a very distinct difference between the two. And I think that's really interesting, and tells us, I think, that we were having quite patient-centred family meetings. And then again, a very patient-centred aspect of these meetings was a real talk about the story of the illness, the changes and losses that were going on, how this family's coping. And then last of all, the management plan, and we all seem to talk about that. So it's very interesting to actually unpack what's going on in these family meetings. We haven't yet worked through to see, I guess, the outcomes of that for the patients themselves. But one thing that impressed me a lot and surprised, I think, all the staff at Calvary was when we asked people, usually within 1 or 2 days of coming into Calvary for the first time, the question, are you at peace? 78% of them said they were. Literally said they were at peace. This wasn't really what... We pussyfoot around this with people, but what they actually said to us, yeah, I get it. I know exactly what's going on. And the things that were upsetting them were actually often their concerns about other people or that they were struggling to accept. I've got some quotes here. Maybe I haven't got quite enough time to walk you through those. But some beautiful quotes from patients about their experience of being at peace or not so much. And the patients really appreciated this process a lot. So we got feedback also from the family members who came. We got 70 feedback questionnaires, more from the intervention arm, obviously. And you can see over half of them just over half were Australian English background, but the other half were actually non-English speaking background. We had a number of family meetings with interpreters. I haven't yet been able to go through all of this data in detail. But mainly the feedback does appear to be quite positive from the families. They were very keen, very accepting, very appreciative. Some have given us very helpful suggestions. Obviously there are some functions that occur in a family meeting where the patient's not present that are different, and it may be that we actually need to think about that as a separate kind of process. But this meeting does meet very specific needs of bringing a family together so that they're all able to understand. So some patients have said, some family members have said even earlier would be better, like day one, which I could imagine would be really helpful if we could get ourselves together to do that. The other really interesting thing is the feedback from staff who've been involved in this process. Initially they were kind of like, this isn't a proper family meeting, we want to do our proper family meetings, but once they'd been to a few, they actually recognised that this was actually quite a different process. And I thought that was fascinating. And a couple of the staff have actually said, this is not just a problem-solving family meeting, this is a new kind of intervention. And they felt their relationship with the patient was so significantly different after the family meeting that they really have valued it. The other thing that came up for me in this process was the family members who have contacted me for the first time actually in my career for almost a debrief very soon after patients died. So obviously raising the issues in the way we did, in the context that was safe for family members, made them feel that they could come back and ask some questions that I think may have been quite significant. So, was my mum aware of what was going on? She looked like she was drowning. What was that about? Those kind of really hard questions. And interestingly, I've never had people come back to me and ask me that stuff in that way before in my career. And I've started to wonder about that. And we as a team have started to wonder about that as a possible intervention. So it's something we're learning from this process. So our conclusions, which are very preliminary, are that these are a very patient-centred intervention. They're very feasible, very much appreciated. We can't yet say we're about to look at the service data to see if it influences length of stay or discharge planning. But we are wondering about whether we are going to be able to impact on family members' bereavement outcomes, particularly if we do some debriefing with them after the death. And so my question is, what are the outcomes we should be looking at? Whether it's about the patient's distress and satisfaction. These patients are at peace, they're telling us. So we're helping them with the problem that's really worrying them, which is being able to communicate with their family about what's going on. So I think the family outcomes are probably key. The service outcomes may or may not turn out to be significant. But what we're following this up with is actually a bereavement study. So we have received permission from some of these patients, some of these family members, to follow them into the bereavement period, and we will chase them up and see how they're going. And that's really the kind of set of outcomes we will be looking at. So there's some problems with this research. It's a small study. It's just a few consultants. We're still developing the research instruments. It's not particularly randomly allocated, just in the inpatient setting. But we're taking it further into the community setting, and we're hoping now to do a multi-site study, so to grow this work, do the longitudinal follow-up of the carers, and really explore this idea of debriefing family members after death, offering them that opportunity if they want to make use of it, and hoping it may improve bereavement outcomes. Thank you very much.
Thank you very much, Christine. It's a really interesting presentation. I kind of wish we had longer for each of them, actually, but time ticks on. So let me introduce, I'm going to read it off here now because I can read that. Tracy King, who's the myeloma clinical nurse consultant at Royal Prince Alfred and a clinical research fellow. Her topic today is real-time translation research in practice, an innovative model of delivering best supportive care in myeloma.
Thanks, Kate, and thanks to the Institute and the conference for accepting my abstract today as an oral presentation. I was quite grateful of that because I really had no idea how I was going to present what really is more narrative than numerical, a bit of a story of a journey in a poster format, so thank you for that. I would also like to say that this is a program that I'm going to describe to you, a journey that has been done in partnership with my co-author on this abstract, which is TBC down here on the front, so Kate's name should be up there also. So So probably a more realistic title for this talk, really, and brief explanation of my journey, is probably to describe an inadvertent journey towards becoming a clinical researcher, because this certainly wasn't a prospectively planned. It isn't something that I thought from its inception that I want to look at this particular area, and this program of research that I now find myself in was something that certainly, looking back at, has been a retrospective analysis of the journey, has been where the insight and the title of a real-time translational research came from, because we realized that actually we were providing a program or developing a program of research, but it really was embedded in clinical practice and was able to be translated into improving of outcomes very effectively. So I'm going to talk very briefly and focus in two aspects. One, I'm going to focus on a program of supportive care research for a population of myeloma patients, but also focus more on the factors that influenced the success and the development and the evolution of this. So very briefly, I'm not going to run through what translational research really is, and I'm sure many of you in this room know more about it than I do, but we're talking about implementation of knowledge into direct improvements of care. And as a nurse working with patients day in and day out, I'm really keen for that to happen in real time and to happen very rapidly. I, of course, am interested in my patients' outcomes in 10 years' time, but I really want to be helping the patients here and now. So we talk about the bench to bedside, to the knowledge being delivered, moving from bench to bedside to clinical practice, and we talk about the domains of T1 and T2 and T3 as to how we translate that knowledge. But really, I think where our program comes in my experience, is in this new area of focus, which is in practice-based research, and I've given that the little title there of T2.5, which you won't find in the literature. That's just my explanation of that. So that's what I'm going to talk about, an example of practice-based research. So this is me in 2011, a myeloma nurse. I was actually working for the Myeloma Foundation at the time on the helpline and delivering support programs around Australia, and also a couple of days a week as a myeloma nurse at Royal Prince Alfred. And this is what was going on in my mind at the time. As you can see from the word map there, I didn't really have a life outside of myeloma, did I? But I had a lot going on. I had a lot of questions. I had patients that I was helping and that were having issues and certainly had unmet needs. And I wanted to apply some research or some process behind how could I translate what I was dealing with on a daily basis into meaningful knowledge that I could then publish and help to improve care going forward. But I really lacked the ability to be able to operationalize that and put that in practice. And it was really an opportunistic event that occurred that was the trigger for me to be able to help translate that and to start to work or to in a slightly different way. Just to focus where the program of research was around, it started looking at what the particular information needs of patients with myeloma were, particularly in 2013, because we live in a different age now in terms of information, but also about the importance of managing toxicities. And Christina's mentioned mood alterations, and certainly that is a toxicity of high-dose steroids in myeloma. And I had questions about these toxicities and how could I understand more about it and then help my patients a bit more. And certainly myeloma is a very complex disease, and that was bringing up questions for myself and my patients. I had a coincidental meeting with TBC, sitting down here, Professor Kate White, who had come into our institution to work and as in a model or a program of bringing the academic and the researchers into the clinical setting. And she came along and had a bit of a meet and greet around the department, and I think she could probably hear my mind going and that I had these questions. And I would always have been somebody very readily put up my hand to say, help me do this, I don't know what I want to do. And Kate helped me and her team really to change the way I was thinking, to reframe these clinical questions I had into research questions, and encouraged me through the very uncomfortable, brutal grant application process and assisted me in that regard to develop a research plan. And we were very lucky in being successful in getting a Cancer Institute clinical fellowship, which allowed me some time to allocate away from the clinical area into the research world and to learn and to be able to translate those clinical questions into research questions. And the focus of that fellowship was to improve the management of toxicities around high-dose steroids in my patients. The beginning of this journey, my training wheels, really was the fellowship. It gave me 12 months months with 0.5 away from the clinical area, and what I learned were new clinical research skills to improve the outcomes for my patients when I was providing clinical care. My clinical questionings became research questions. I learned the importance of data collection and data management. I learned more about research methodologies and analysis, and we applied qualitative and quantitative analysis to this project, which I won't go into. I've presented many times before. And I was taught and mentored to start looking at my questions and my world and from a macro level, and my horizons were more sort of national and global, and what's going on, what are other clinicians doing in this space, and what can I apply into my world where I work at RPA. And certainly I was having different conversations. I was questioning my patients more. You know, you have that toxicity, but what does that mean for you, and what can we do, and what do we need to do about it? And it was a two-way process. The mentorship I received during the training fellowship from Professor Kate White and her team in the Cancer Nursing Research Unit certainly provided me with the resources and the training to be able to be guided in all aspects of research. They encouraged me and certainly pushed me out of my comfort zone. I'm somebody that likes to get out of my comfort zone, and I've joked before that Professor Kate White pushed me straight off the cliff of my comfort zone, but I think I'm hanging off the edge of that cliff by a fingernail now. And they began to help me ask those questions. I'd come to them in the department and say, oh, this patient has this problem X, Y, and Z, and they would say, why do they have that problem? What do you want to do about it? And they'd reframe it and send me back out the door into the clinical space with another mindset. And of course, the importance of data. So after 12 months that completed, and on negotiating a contract ahead and to remain funded and as a nurse at RPA, I was able to negotiate a change in my physical location, which was really just up a floor or across a corridor, and I became embedded as a clinical fellow within the nursing research unit. And that really didn't have any meaningful change in terms of my ability to deliver patient care, because it was just up a flight of stairs or across somewhere, but it really did have meaning in many other ways. In terms of the program of research, I'll very briefly show you this slide in terms of what we were doing. I'm down there in the pink box in the clinical practice environment, and certainly all of my interests and programs of research have been very much patient and carer-centred. They have been at the core of every question I have had. We identified supportive care gaps, and I've spoken about those being in the domains of information needs, and particularly around the toxicities of steroids, and we undertook a pilot study to really find out what was going on and what were their experience on high-dose steroids, because it was all anecdotal up until that point. This is evolving, though. This is not a process when I went back into the clinical setting where I went to my bad old ways of just having clinical questions. I had a new frame and a new mindset of how to solve and manage that, and I'd go from my clinical setting back into my desk in the research environment and come back out with very different answers. And this is evolving. At the minute we're around probably, do we have a pointer here? I'll try not to change the slide. This is what I did within my fellowship, and now I'm probably here. I'm taking the findings from that fellowship towards the development of a patient-reported outcome measure, a tool, and I will be doing that in conjunction with my patients and my other co-investigators. But what we're also looking at now are a variety of other research questions, the polypharmacy in the elderly in this population, administration of certain agents that are changing, and we need to think of different ways of delivering them, and very pleasingly, which is linking into a lot of what's been spoken about today, the role of primary health care in improving the care of patients with multiple myeloma. And at every step of the way, this is being translated straight, because I am embedded in clinical practice, but with a different mind frame now, into changings that are happening in the clinical place on a day-to-day basis. I'm having different conversations. I have data now to voice and advocate for my patients, and timely interventions from some of the outputs from these studies are happening in real time. What are some of those, very briefly, that have come out of some of the work we've done? Well, we've certainly disseminated our findings at national and international conferences, and those papers are ready for publication now. We've developed a range of improved resources based on the findings from our studies around information needs, and those are disseminated not only within our organisation, but also via the Myeloma Foundation on their website. So nationally, patients can access improved information resources. We've got tools that I use in the daily setting to help with adherence to complex medication regimens, and also the findings from the study are being fed directly into myeloma support groups and family seminars that are held very regularly, locally and nationally, and also obviously the uptake by the wider team in haematology. And we've also done some other information that have come directly out of studies, improved fact sheets, and these also, that's not fish and chips, as somebody said, that's fish and steroids, which probably are not as palatable as fish and chips. But the use of complex testings and diagnostics, patients want to know what the meaning of these are, and we can very readily whip up a fact sheet that doesn't just come out of RPA, but also goes nationally to the Myeloma Foundation, and also the findings from the steroid study are disseminated very readily. So as well as the program of research that, and patient participation, there's also an evolution of myself as a clinical researcher, and that can be shown diagrammatically here also. I mean, the relationship, my working environment, this is me the clinician, and embedded in the nursing research unit at RPA, allows the findings to be disseminated very quickly into the at a local level, but also my learnings and my evolution as an early career researcher, I pass that back down to my junior staff on the ward, and we're encouraging people to put ethics applications in, and we have some posters going in for a national conference, which is a first for some of my colleagues there. So the benefits from my mentors to me are down going onto the ward, but also nationally. The outputs and the findings from the work that I've done in the last couple of years have certainly been shared at a local and national level. And what has happened there is that I've been invited to participate as a chief investigator on an NHMRC partnership grant, looking specifically at patient-reported outcomes because of the findings from the work we've done. Also able to influence with direct leadership the Haematology Society Nurses Group in terms of improving quality and criteria for abstracts and advocating for education and research in this area as well. Research and professional collaborations are also occurring at an international level, and I am leading the International Myeloma Workshop nursing program with some nurse practitioners in this field internationally. And we've already had some shared visits occurring, and we'll be working on collaborations and research projects going into the future. Also been able to advocate and lead for improvements in supportive care research funding because of my increased involvement on professional bodies. And it is with my involvement with the Leukemia Foundation Scientific Advisory Group that I've been able to help influence and advocate for the need for more financial grants and money to support supportive care research, and this year was the first time we had a grant for that, and we had 22 applications, which I think blew away my sort of medical colleagues in terms of all the research funding and grants that were very much biomedical. So thank you so much for people that put grants in for that. And also in terms of part of my evolution now, I have been mentored and supported and find myself enrolled on my PhD, so the evolution goes on. So where am I now? Well, I think my mindset has tidied up a little bit. I've become a little clearer and perhaps maybe more articulate and able to operationalise the questions I'm getting in my clinical setting, and being able to take the problems from the patient that I am managing on a daily basis back into the research unit, discuss and dialogue that over a Thai lunch every Friday, which is where we solve the problems of the world, and go straight back out into the clinical setting with another research question and badger many of my colleagues and friends to participate in that. Some of the critical success factors in completion, I would have to say, is certainly that as a researcher, I am a clinician foremost. I am an early career researcher, but I am primarily a myeloma nurse, looking after patients in the clinical setting. I'm able to find and create data that is directly relative to the patient. So that is data or outcomes that are subjective and that are focused around the patient here and now in the clinical setting. My patients and carers and family members have become research partners, and that is important and crucial. If you begin to read the research in this area, you will see that advocated for. The support of the haematology team and my medical boss is absolutely crucial, and I thank them for that, but also the initial funding that gave me the time to train and to form and get my training wheels in this was also very, very important. And most importantly, the geographical position and location. I find myself in the hospital at RPA in the clinical setting, but actually sitting within a research unit that has a supportive care focus has been absolutely crucial, and I think has probably a bit of mutual aid going on there, a lot of shared learning. So in conclusion, I'd like to acknowledge the other people involved in this, of course those affected by myeloma that I have the privilege to care for, but also Professor Kate White, who is my partner on this project, and the Institute of Haematology and the Cancer Institute. And I thank you for your time.
Judith popped back in. I wonder if you'd mind just coming up very quickly to the table, because we do have, thankfully, some time for questions. And if you've got a question, there is a microphone there, which is on. So has anyone got a burning question that's come out of any of the presentations? I've got one to start off with. Judith, if I can start with you, if that's okay. I guess one of the things that, I was wondering as you started and you got to that point at the end, which was you can't do this without good secretarial support.
No, absolutely not.
And I think that's often the challenge around MDTs, because there isn't a clarity about who pulls all that together and whether it's someone that's in a clinical role or someone who's in an administrative role. Do you have a comment?
Look, it takes a lot of work from our secretary. It also has taken a lot of work from one of our research data managers, who's, Jimmy, who's got a degree in information science, in terms of that constant reformulating the Proforma around which it is all very structured. I think the only answer that we could give our poor secretary, the one poor secretary who took this on, is we had to redistribute some of her workload to the other secretaries, was the fact that impressing on her that this was key. This was actually far more important than even a patient clinic letter. All right, and this was absolutely key to delivery of our commitment to, world's best care locally. And then as we've got the SOP much more streamlined and we worked out all the glitches, she has devolved a lot of the reporting to individual haematologist secretaries. But it's a constant problem, as everyone has in the public health system, the secretarial support.
Yeah. Can I just ask you one other question? What happens to that form? Mm-hmm. Does it go into the patient's record?
It goes 3 places. It goes into the patient's clinical outpatient file. It goes posted to the GP. And it also goes into the electronic medical record. However, it is somewhat lost in the electronic medical record because we have yet, and we continue, and I can give you 20 different emails, ping-pong emails to our head of IMTD. We want to have it in the multidisciplinary team highlighted thing on PowerChart on Cerner. But the current Cerner option that they insist we use, because they don't like us using an external, data form, is just not feasible. So in the end, we just bypass them and we post it in where the outpatient letters go. This is a shame, but we'll work there.
One other question. What proportion of all of the new patients are actually presented using this format? Do you have an idea?
We probably think it's well over 95%.
Wow.
I think the people who are not getting presented are the people in whom we do nothing for treatment. And that's 95% of eligible patients, and we do not include CLL patients who do not require treatment at diagnosis. We don't include monoclonal gammopathies. So there's a few things that we, not interested in capturing, but by far and away the majority. Yeah, it's become expected. It's just become in the culture. Yeah.
Very interesting. I'm just keeping an eye on. Christine, I've got a question for you. The gender difference was interesting in both groups. What are your thoughts about why you think there may be more men who put their hand up for this than women?
I'm really not sure. I hadn't actually picked it till I looked at the data, and that's only happened in the last couple of weeks. So and then I've been on leave for a couple of weeks, so I haven't had a chance to sit down and have a proper think about that. I'm just not sure. I don't think it's I don't think it's that the female patients wanted it less or benefited less from it, so I'm not really sure what's going on.
I mean, I must admit, I wondered, whether women have had those conversations with family. Is that something that there is a sort of mothers, innately have that kind of role, or do women talk more readily before they come?
It may well be, and I think when I go back and look at it, I'll look more carefully at marital status and the relationships of the other people at the meeting.
Yeah, very interesting study though.
But it was the patient that had consented, not the family.
Yeah.
So the family, the patient consented, we held the meeting, and then what the family could agree to or not was whether or not they filled in the feedback form. They didn't have to.
Right, that was another question I was going to have, so... Very interesting. So where you'd go next is obviously in a bigger multi-site study.
We'll put it into our community setting first, because that's the other site, I guess. I guess we're looking at transitions and trauma points for people. So being referred to palliative care is a point of kind of like, oh my God. So that's what we're trying to kind of ease people through, and to meet people at that point and see what they want from us and what they want to tell us about themselves. So admission to the community team is the other point we'll look at now. But we've just got the funding for that. We have to go away and sort of nut out how we go about that.
Very
so
interesting.
It could be quite complex.
Yeah, look forward to hearing about that one next year.
Yes.
Tracy, if you had 3 tips to give to a clinical nursing colleague who might be interested in doing something about improving a single aspect of practice in their work, what would those 3 tips be?
Number 1, I'll give you Kate White's email. That talks to, don't feel you're alone. I mean, I think different professions within healthcare have a different culture of or ability to undertake, or even understanding of the language around research. And in medicine, I think it's within your culture. You publish or perish or do work and get out there. And it's not really been in the culture of nursing. It doesn't mean it shouldn't be, but I think go and find somebody that can help you. So find a mentor. Opportunistically, Kate sort of landed at my door and just sort of said hello, and I thought, oh, she might be able to help me with a question I have. So go and find somebody that can help you, and if you don't know where that person is, then really do either email myself or Kate, and we'll find somebody for you. Number 2, I mean, work in a group, not in isolation, I think. I mean, use your clinical colleagues. I mean, go to your medical colleagues. Find somebody you can talk to and say, I've got a question, can you help me? Are you interested in this? Is this something we as a team could do? So find not only a research mentor, but also a mentor within your department that can help you. And also, I suppose, I mean, the fellowship helped me, but that came sort of chicken and the egg, didn't it, really? It came after I found a mentor, but in no particular order. Then if you can find and apply for, there's no reason why nurses and people interested in supportive care research can't be applying for and getting fellowships and grants and seed funding in isolation or as part of a team to help you do what you want to do. Be that to get some secretarial support, or somebody like Jimmy who has these amazing skills that are important for the team, and you can buy into that, or to secure you some time, even if it's 2 hours a week away from the clinical setting, so that you can get your head down and do that work. And really, it's only by getting out there and creating a voice for supportive care research that we can get some traction on this and develop supportive care research as a crucial part of our as research in cancer services.
Tracy, can I perhaps say that for nursing research in general? I know, there are so many nurses out there who spend 100% of their time in clinical research, and yet they don't think of themselves as being potential investigators. And I remember one of our research nurses, our myeloma research nurse, came to us and said, who's going to be the investigator on this project that the psychiatrist is actually running. I can't believe you don't know this is happening, and we're working in our own silos in our own hospitals, looking at steroid effects in patients on lymphoma and myeloma. And I said, well, why can't you be the investigator? I think nurses who work in research need to think beyond just, being research managers and study coordinators to actually developing their own research ideas, because they're the people who've learnt the tools, who know the structure.
And they're the ones that are often also dealing with the consequences that the patients experience, so they can actually change it.
And in our project, the thing that really excited me was seeing the social work team and the pastoral care team getting really interested in this as a research process and recognising that, you know, the things that might worry them about how we work, they can actually ask methodical questions about and learn from. So that's been exciting to see some new people.
There's a theme for next year's conference. Can I ask you all, I'm conscious that it's probably afternoon tea time, can I ask you all to join with me in thanking what have been 3 fantastic papers. Thank you all very much.